Hello, and welcome to Bite Size MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on granulomatosis with polyangiitis, formerly known as Wegener's disease, under the section of rheumatology. What is granulomatosis with polyangiitis, or GPA for short? It's an ANCA-associated vasculitis, and it's a necrotizing inflammation affecting the lungs, kidneys, and small to medium vessels. As for its epidemiology, it's the commonest type of ANCA-associated vasculitis, and its peak is between the age of 40 to 50s. It has an incidence of about 4 to 9 per million globally, and it's slightly more common in men than women. The etiology of it is that it's an ANCA, or anti-neutrophil cytoplasmic antibody driven type of vasculitis. And for its signs and symptoms, it's really quite varied depending on the case. However, typically you will see a triad of upper respiratory tract, lower respiratory tract, and a renal involvement. As for its other signs and symptoms, especially in terms of the timing of things, it could be quite indolent and present for instance, with recurrent of sinusitis that's not resolving despite antibiotic treatment, or in extreme cases, it could present as a rapidly progressive glomerulonephritis or even pulmonary hemorrhage. Just to divide it a bit further, the other signs and symptoms that you would be looking for, especially in terms of PACEs, if you end up getting one of these cases, is really thinking quite broadly. So particularly, you would want to be asking about musculoskeletal symptoms, which is common in about 60% of patients, and it can be varied between myalgia, arthralgia to arthritis, and a migratory arthralgia is quite classic in this syndrome. Ear, nose, and throat symptoms affect approximately 90% of patients, and as I mentioned, classically you would see somebody who is coming in with recurring cases of sinusitis that's not resolving despite antibiotic treatment. Sometimes there can be mentioning of nasal crusting or even septal perforation and the collapse of the nasal bridge. It very frequently affects the respiratory tract up to 80% of cases, and it can really range from pulmonary nodules all the way to hemorrhage. Moving up to other signs and symptoms, renal involvement is really common, and about 90% of severe cases of GPA will have an element of renal involvement, and this can range from focal and segmental glomerulonephritis all the way to rapidly progressive and crescentic glomerulonephritis, which ultimately will unfortunately lead to end-stage renal disease. And the other systems that are quite commonly involved are skin and nervous systems. In terms of skin, you would see classically your palpebral purpura or vasculitic looking rash, and in terms of nervous system, very frequently it can affect the different nerves, so you would end up getting a pattern of mononeuritis multiplex. As for the investigation that you would want to do in somebody presenting with a possible cause of GPA vasculitis, the key again, as many other diseases in medicine, goes back to your history and then your clinical examination. So really you want to be asking about all of those signs and symptoms that we talked about as part of your history, and you, depending on what information you gather from your history, you would want to target your examination on that particular system. However, it's crucially important to have a systematic order of how you're approaching these cases, especially in terms of your PACEs. So starting from bedside test, you would want to do a full set of observations, especially thinking about having a temperature and also your blood pressure. In the case of vasculitis, you would want to ask for a urine dip to check for hematuria and proteinuria on your dipstick. Then you would move on to have some blood test. So you would want to check your full blood count to check for any evidence of anemia or infection. You would want to be checking your renal function in case they have renal involvement, liver function, and inflammatory markers such as ESR and CRP, which very frequently are going to be elevated in the cases of the GPA. Then you would move on to your more immunological testing, which is going to be your crucially your ANCA, your ANA, and your connective tissue disease screen. The specific ANCA that's absolute MRCP favorite, especially in terms of multiple choice question for the case of GPA, is going to be C-ANCA, which is going to be against PR3. Then you would move on to further detailed investigations, and that is to have your chest x-ray, as you would do for anyone who's presenting with potentially pulmonary involvement, and then also you would want to be very frequently, especially in real clinical practice, you would want this patient to have a CT thorax, abdomen, and pelvis to make sure that there isn't any other possible cause for their presentation, such as malignancy, which is frequently the other sort of big differential in the case of vasculitis. And then finally, the absolute diagnosis is made based on a tissue biopsy, and that very frequently is going to be a renal biopsy. As for its treatment, the treatment is like many other chronic conditions in the UK are going to be treated based on the MDT approach, and that is the involvement of your colleagues within the multidisciplinary team, such as physiotherapists, occupational therapists, dietitian, as well as other specialties as appropriate, such as renal physicians, respiratory physician, dermatologists, and rheumatologists. And broadly speaking, the management is divided into two categories. One is for induction and the other one is for maintenance. The induction is obviously to get on top of the flare, and very frequently for that period you would be looking to use corticosteroids and cyclophosphamide or rituximab based on availability and also your specific trust protocol. And then in terms of your maintenance, really the drugs that are commonly used are going to be azathioprine or methotrexate. So let's do some questions. Which of the following may be used for induction therapy in a patient with severe GPA? 1. Adalimumab. 2. Rituximab. 3. Etanercept. 4. Tocilizumab. 5. Azathioprine. And if you remember from the last slide that I just talked about, you will recall that the drugs that are going to be used for induction are going to be either steroid with either rituximab or cyclophosphamide. And obviously based on that, case 2 or option 2 in here is going to be the correct option. Question 2. Which of the following is not a first-line investigation in someone with suspected ANCA-associated vasculitis? 1. Blood pressure. 2. Urine dip. 3. Chest x-ray. 4 CT angio, 5 ECG. And you don't necessarily need to have a very detailed knowledge of vasculitis to answer this question. You would just need to have a systematic, practical approach when you're answering, which is really key, especially in terms of your PACES exam when you're presenting your findings and you're talking about how you want to manage a certain condition. So any patient that comes in obviously will have their news chart taken and their basic observations. So by default, you're going to be having blood pressure as part of your panel. Then, if you recall, we talked about the importance of having urine dipstick in cases of suspected vasculitis to exclude renal disease, particularly looking for hematuria and proteinuria. So option 2 is not going to be the correct option. Chest X-ray on the same line. You will remember that anyone who's presenting with pulmonary problem, whether that's shortness of breath or chest pain, you would want to be doing a basic chest X-ray to make sure that you're not missing something else, basically. And ECG is going to be somebody who, again, as I said, who's presenting with shortness of breath and chest pain. It's not unreasonable to do an ECG to make sure that you're not dealing with a cardiac problem in here. So really the option that is not going to be as part of a first line investigation in someone with a suspected ANCA-associated vasculitis is going to be a CT angiogram. Make sure that you don't fall into the trap of thinking that anyone who has a suspected ANCA-associated vasculitis is immediately going to get a CT angiogram as the first point of call, because that's clearly not how the practice works. Thanks for listening to this episode of Biostats MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.